asymptomatic, sir. Case of hyponatremia.
Yes, man. Child is symptomatic, and that's what I'm telling. Child is symptomatic. You give an acute treatment. You found out the cause. Then what you're going to do? I'm asking. For example, hyponatremia. Child came with seizure. So you given 3% bolus. Then child is getting better. So now what you're going to do?
The volume status of the child we should know first.
That's what I'm telling you. Follow the cause. Cause is there. You do whatever cause you found out, then what you're going to do? How you're going to correct the sodium? I'm asking. Based on what you're going to correct the sodium? Is about the underlying treatment? Sorry, I'm asking underlying problem or depending on the something else. The rapidity of correction dependent on what?
Type of hyponatremia.
Rapidity of correction is dependent on what? It's not the type of hyponatremia. It is chronicity. Acute or chronic. In chronic electrolyte disturbances, you need to correct them slowly, especially sodium. So the next step after finding the cause is what is the chronicity. Acute hyponatremia, you can correct little faster. Chronic hyponatremia, you need to correct very slowly, not more than 10 milligrammes per day. Understood? Then comes if you have multiple electrolyte abnormalities, say hyponatremia, hypokalemia, hypocalcemia. So how to deal with these multiple electrolyte abnormalities? Which one to correct first? And correcting one can improve other, or it can decrease the other. So based on this, so you need to approach. This is the basic approach for electrolyte imbalances you encounter in the reports. So with this basic approach, last time we discussed how to manage hyponatremia, hypernatremia, hypokalemia. So now we'll move on to hyperkalemia. What is hyperkalemia? So we need to move quickly. So I'm not talking anything extra here. So hyperkalemia is in and out you're managing regularly. So what is hyperkalemia? Definition of hyperkalemia?
Serum potassium more than 5.5 milliequivalents per liter, sir.
Okay. What are the symptoms of hyperkalemia? Symptoms. Symptoms are different, signs are different. What are the symptoms of hypokalemia? Hypo, I'm not asking hyper. What are the symptoms of hypokalemia?
So lethargy, ileus,
Okay.
muscle weakness, sir.
Muscle weakness. Okay.
Abdominal distension, not passing through.
Paralytic ileus. Muscle weakness in very severe cases. So like that, what is the symptoms of hyperkalemia? That's what I'm asking. Can you see any child coming with some symptoms of hyperkalemia and you identified this is a symptom is due to hyperkalemia, we'll treat it. Any symptoms? Child coming to you with some symptoms and that you are thinking that symptoms are due to hyperkalemia. Any guess? So like you told, serum potassium more than 5.5 in pediatrics and more than 6 in neonates is hyperkalemia. And symptoms are very rare even in severe hyperkalemia. So never expect symptoms for hyperkalemia. So you need to suspect hyperkalemia. And rarely they can present with muscle weakness and sometimes palpitation, syncope, and majority of times we'll see them in cardiac arrest. If you want to see for the symptoms, the main symptom or main presentation is cardiac arrest. So then only you realize, okay, something is abnormal with this child. Most probably we'll look for hyperkalemia and we'll start treating them. And you need to pick them early. You need to have ECG monitoring. So clinical signs and symptoms are very rare in hyperkalemia, except you identify the hyperkalemia during cardiac arrest. And by with ECG, we can identify in a little early phase. So what are the changes in ECG you get? The first change is?
Salt erase.
What is tall T wave?
So more than half of the QRS complex, it is tall T waves.
Yeah, more than half of the R interval, R wave amplitude.
R wave.
So next is prolonged PR interval, widened QRS, then disappearing and absent P waves. Finally, child can land up in ventricular tachycardia. So this is so tall T waves you'll get usually when potassium is more than 6, and your PR interval will be prolonged and wide QRS will happen when it crosses more than 7, and you'll go for sinusoidal wave on VT when it crosses more than 9. So this is rough values, but any child can develop any ECG change at any point of time depending on the rapidity of the potassium increase. Sometimes the child had potassium of 3 and potassium increased to 6 also, child can develop your ECG changes. So never ever think that this is the guidelines and this child will not get any ECG change if potassium is 5.8 or 5.9. It depends on the rapidity and increase. So what are the causes of hyperkalemia? Common cause of hyperkalemia. You can classify. Can we classify the causes of hyperkalemia? So any electrolyte imbalance, there are only 3 to 4 reasons. One is you take more, you excrete less. So that's the two things. Or you increase the production inside the body itself. Sometimes it can be redistribution from inside out, outside in. So these are the main causes for any electrolyte imbalance. You no need to worry about causes classification. If you remember this 4, that is enough for anything. So decreased excretion, increased production. Increased production can be increased intake as well, and redistribution. These are the main causes. So I'm not going to go through all these things. So mainly increased intake is more nitrogenic. So many times the hyperkalemia, what encoded in hospital settings is mainly iatrogenic potassium administration. So be careful how much amount of potassium you are giving, and monitoring daily potassium is essential to prevent iatrogenic hyperkalemia. And other things like AKI, drugs. So there are other things which can cause hyperkalemia. So please go through them. I'm not going to discuss. And investigations mainly you have to look for RFTs, because if you give more also, if kidneys are getting excreted normally or they can increase the excretion, hyperkalemia generation is very rare. So if they're not able to impaired kidneys and increase in the load, it is a main common culprit for hyperkalemia. So that's why always look for the RFTs. And sometimes we add abnormal electrolytes, other electrolytes, and metabolic acidosis can trigger hyperkalemia by shifting the. So with this background, so we'll go through the case scenario. So this is a 1-year-old post-operative child. The child is in hepatic jejunostomy underwent, and he was on maintenance fluids, and he was on 40 milligrams of KCl. So what this 40 milligrams of KCl is normal maintenance or supranormal maintenance? $40 milligrams per liter of KCl.
Normal maintenance.
Is this normal maintenance? So it is extra. 20 milligrams per liter is normal. So you're giving double the normal maintenance. And you repeated potassium after 2 days. So you're not repeated daily. So whenever, the first point I told in hypokalemia management is, whenever you're giving extra potassium, you need to repeat electrolytes daily at least. So here we not repeated daily, and we repeated after 248 hours, and we found that potassium is 6.3. So the next question is here is, so already we found out the cause for hyperkalemia, most likely iatrogenic, but when your kidneys are functioning well, this should be get compensated. So to some extent, maybe we need to rule out AKI in this child. So the question here is, how will you manage this child? So 1-year-old child and extra potassium supplements found to have potassium of 6.3. So how we are going to manage this child? First, we should connect ECG leads.
Look for ECG changes.
Yeah.
And
Yeah, ECG connected. Fine. ECG
so
change.
first we should stop the source. We should stop the fluids immediately.
Yeah, you connected the ECG. You stopped the source. You stopped the fluids. You change it to normal without potassium fluids, and ECG was normal. It's not all T waves. So how we are going to manage this check?
Sir, as it is above six, so we should be giving corrections.
Which corrections? That's what I'm asking.
First, we will give calcium correction, sir,
Why you are giving calcium correction for in hyperkalemia?
to stabilize membrane, to prevent arrhythmia.
To stabilize membrane. But there's no tall T waves here, right? The membrane is stable only. So what you are going to achieve by giving IV calcium gluconate when membrane is already stable?
So it's first to cut down the source, sir.
Yeah. Already she cut down the source, she connected ECG leads, ECG was normal. So she want to give IV correction. That is first is calcium. So that's why I'm asking, when already cardiac membrane is normal, it's already stabilized, why you want to give calcium? That's what I'm asking. What is the half-life and action of that? How much time the calcium can act? Any guess? No, I'm not asking pinpoint like 2 minutes, 3 minutes. You can give the range. Hmm? Yeah.
10 to 15 minutes.
Yeah, roughly half an hour. Yeah, so half an hour to 1 hour, it's good. It can take half an hour to 1 hour time. Fine. Okay. So did you feel that this calcium is going to stay there and it keep the membrane stabilized when already membrane is stable? Prophylactically, you're giving calcium. Fine. You can see what the guidelines telling, and your concept of giving calcium to stabilize the membrane is correct. But when to stabilize the membrane, we need to just see. And second thing, what else thing you have to give?
Bicarbonate.
You want to give bicarb. Why? Why you want to give bicarb?
Salbutamol. So for transcellular shifting, sir.
Transcellular shifting. Okay. So for all patients with hyperkalemia, you want to give bicarb. For all children with hyperkalemia, you want to give bicarb for transcellular shifting. Kitna? You tell you want to give 100% for all patients or not, or only selected patients? That's what I'm asking. Nothing I'm asking.
For all, sir.
Okay, you want to give for all. Okay, fine. Anything extra you want to give?
Salbutamol nebulization.
Salbutamol nebulization. How it going to act?
So that also by transcellular shifting.
Okay. Anything else you want to give?
So to remove it, we can give either a furosemide or a K-bine.
Okay, give furosemide and K-bine. Okay.
But for 6.3, we can wait, sir, without any tall T waves, all these things.
Okay, fine. I think everyone got the point what you are talking. We'll see what is the correct answer for this scenario. Now we'll move to case scenario 2. This is a 19-day-old neonate, poor feeding and activity, history of decreased new output, no output from the morning, he was lethargic, almost gasping, severe dehydration, shock, ECG showing tall T waves. He has a weight loss of almost 800 grams. Potassium was 6.9 in this state. So ABG showing severe metabolic acidosis. So dehydrated child in shock, ECG showing tall T waves, potassium was 6.9, and ABG severe metabolic acidosis. What is the cause for hyperkalemia here? What is the likely cause for hyperkalemia here?
Renal failure, sir.
Yeah, it's renal failure. And how are you going to manage this child? Potassium 6.9, ECG showing tall T waves.
The first connecting is ECG we have connected. Then
Tall T waves.
we should start dehydration correction.
You want to start dehydration correction. Okay. Fine. You want to give fluid bolus to improve the shock. Okay. But the ECG is showing tall T waves. You don't want to act on that.
Sir, along with calcium correction for this child.
How much you are going to give calcium correction? How much fast you are going to give? So what is the dose and what is the duration? How much fast you are going to give calcium correction in this situation?
1 to 2 ml per kg over 15 minutes, 15 to 20 minutes, you can give sir calcium. By the time we can start on salbutamol nebulization, followed by bicarbonate correction, same 1 ml per kg, we can give over 5 to 10 minutes.
Okay, anything else?
And we can give K-bind along with this also.
You want to give K-bind? Anything else? Listen, severe hypokalemia, AKI. Anything else to stabilize this child?
To support.
Apart from bicarb, salbutamol, you cannot give a child is gasping. You cannot use salbutamol and gasping child. You need to intubate this child. So anything here in the ER, what you can do? Anything extra? Anything which can cause shift of the potassium inside?
Insulin dextrose.
Yeah, insulin dextrose. Any dose?
Point 1 unit per kg.
0.1 unit per kg. Along with that, anything you want to add, or just will give
0.5 grams
10%
per kg sugar.
Okay, fine. So let's combine the insulin with dextrose. So these are the drugs what we discussed already. So calcium gluconate is mainly for stabilization of the membrane, and onset is very immediate, and the duration is only for 30 minutes. So you cannot keep stabilizing the membrane by repeating the calcium gluconate. Understood? So you need to continue calcium for every half an hour to stabilize the membrane, because your potassium is not going to come down immediately if you want to do it prophylactically. I think everyone agree what I'm talking. So when you once you decided to give prophylactic calcium gluconate for hyperkalemia without ECG changes, your goal is to repeat it every half an hour to 1 hour until your potassium is normalized. So remember this one point. And the other things are shifting agents, intracellular shifting. One is salbutamol. So action starts at 20 minutes, and it will work duration of 2 to 4 hours. And insulin, it will start after 20 minutes and it can work for 4 to 6 hours. So like we discussed, if you don't have central line, in dose is 0.1 unit per kg with 5 ml of 10% dextrose, 5 ml per kg, 10% dextrose, IV bolus. It's bolus. You can just give it off. You can only to give it as an infusion. And this is the ER management. So, but if you're still having persistent hyperkalemia, you can start infusion of insulin. You can go up to 0.5 units per kg per hour, along with the dextrose to maintain the sugars. The other thing is to remove the potassium from the body. So all these three will going to stabilize. One is stabilizing the membrane. Another thing is just shifting the inside. After once the action is gone, they can shift back into the blood. So we need to remove it from the blood as well. So for that, we have two agents. One is through kidney. You can give furosemide if kidney is working well. And if it's kidney is not working, you need to remove it through the gut. So that is the potassium binders, resonium. So these are the things. And that one more thing is bicarbonate. So we'll give only bicarbonate when the pH is less than 7.35, because it doesn't have that much action of shifting potassium inside when your pH is more than 7.4. Some action will be there, but it's not that much action we expect. If you have acidosis, you know that acidosis can shift the potassium out. So in acidotic patients, the bicarb will do the wonder. But in normal pH patients, the bicarb role is very much less. So you need to think of other things, salbutamol and insulin, rather than relying on the bicarb. That's one point I want to stress here. The commonest mistake what we're going to do is we're going to give calcium and bicarb. Then only we'll think of salbutamol and insulin. So you need to think what is the underlying acid-base status of the child. So the first scenario where you're treating hepatic or dyselectrolytemia patient, their acid-base status will be mostly normal. So there your bicarbonate has not much role, until unless child is having some dehydration or something which is causing a metabolic acidosis. You don't have that much role in first scenario. But in second scenario, you know the pH is very less acidotic state, so you need to give more bicarb in for that child. Apart from that salbutamol and insulin, you need to try more bicarb to correct acidosis. So with this, we need to go for the algorithm. So you found that hyperkalemia, and when you need to confirm with the urgent ECG, and ECG showing normal ECG, and potassium is very mild. The potassium is 5.5 to 6. See the mild variant, mild hyperkalemia, 5.5 to 6. The step one here is you need to stop the fluids. Ideally, what we did for the first patient. And you have to review the medication, all the medication child is getting. So some patient will be getting enalapril, some patient will be getting spironolactone. So you need to stop all these medications. And you need to consider whether treatment is necessary. If necessary, you can try your salbutamol NEM, or you can give some K-binder if you think the child might need, because child might progress. So some drug is there, we just stop it. No, it may, but action going to take some more time, and potassium can go up. If you think the potassium, if just fluids, you can just wait and watch. But if you feel there is some other culprits also which can increase the potassium, then you can try giving this salbutamol resonium for this kind of children in mild cases. In moderate, like potassium is 6 to 7 with normal ECG. So same thing, you need to stop the sources. Then you need to lower the potassium. You cannot, but see here, even with 6.1 to 7, with normal ECG, they are not advising calcium gluconate, because the prophylactic calcium gluconate has no role when you have moderate hyperkalemia. So if you prophylactic have to give, you have to keep repeating them. So that's why they are not advised here, and it seems logical. And you cannot wait here till the ECG changes happen. So you need to lower the potassium. So in that, the first step is salbutamol, insulin glucose, and you need to consider bicarbonate when the child is having metabolic acidosis. Also, you need to consider furosemide and resonium for the excretion. So inside shift, and along with that, you need to excrete it. Next, if you have severe hyperkalemia, that's potassium more than 7 or more than 6.5, ECG changes. So any child with ECG changes, it is significant, it is severe. So you need to stabilize the membrane. So first protect the membrane by giving calcium gluconate, then lower the potassium and promote the excretion. In this situation, if you have renal failure and you cannot be able to excrete the potassium, you can consider RRT. So this was the guidelines given by Royal Children's Hospital, Melbourne. So only in case of digitalis toxicity, you need to give calcium very slowly. Otherwise, you can give it over 10 to 15 minutes in case of symptomatic hyperkalemia. So symptomatic hyperkalemia, the calcium has to be given faster, little faster. You cannot wait for the child to land up in further ECG changes and VT. So like what you give in resuscitation. During resuscitation, how you're going to give calcium, like that you need to give it little faster. But if you want to give calcium in a child with normal ECG, then you can consider slow calcium, like half an hour to 1 hour. There is a major difference. But in symptomatic hyperkalemia, ECG changes, you cannot give calcium over half an hour to 1 hour. There's no point of waiting for half an hour to 1 hour so that the child can turn up in other arrhythmia. So these are the main guidelines for hyperkalemia. So consider it is mild, moderate, severe hyperkalemia with or without ECG changes. Without ECG changes, mild, just to give symptomatic treatment like stopping potassium, stopping drugs, and if required, just to give salbutamol and excretin agents like resonium. Moderate hyperkalemia without ECG changes, consider giving shifting agents along with the excreting agents. In symptomatic, that is ECG changes with severe hyperkalemia, you need to give protection of the calcium because you don't know when the heart can start reacting to the hyperkalemia. So you need to keep providing prophylactic calcium even every half an hour or 1 hour till you get a potassium less than 6.5. And then you need to promote the potassium excretion by the resonium, furosemide, or if not responding, dialysis. I think I'm clear on what the guidelines are telling and hyperkalemia management, and you should know why these guidelines are like this, because so calcium is mainly for membrane protection and it's no role for when membrane is already normal, and other three are mainly for shifting, so they can be helpful in moderate hyperkalemia. And along with that, you need to excrete the potassium, so you need to consider other excreting agents like furosemide and resonium. So we'll quickly finish hypocalcemia. So hypocalcemia is depending on what calcium you are doing, whether you're doing a total calcium or ionized calcium. So depending on that, so main signs and symptoms of hypocalcemia: neuromuscular excitability. So it is mainly seizures, muscle cramps, tetany, and your paresthesia, scarpopetal spasms. What are the signs of latent tetany? We'll do two signs. We'll say two signs for latent tetany.
Rogers sign and Chevrolet signs.
Okay, good. So, and ECG changes in hypocalcemia are prolonged QTC and conductive abnormalities with bradycardia. So, this is one thing you need to remember in any child with lower heart rate. Just see for any calcium abnormalities as well. So, electrolytes are must in any heart rate abnormality. Either heart rate is high or heart rate is low, always check for the electrolytes. The main infants will be jittery. The main thing is jittery. They can have tremors, seizures, residual feeding, tachycardia, so laryngospasm, mainly laryngospasm component in infants, and neonates you need to rule out hypocalcemia. So the signs are Chostek's and Prosue signs. This is the Chostek sign. So you tap at the near the tragus, you feel the contraction of the facial muscles. And Prosue signs is you need to inflate the BP cuff more than 20 mmHg about your normal systolic blood pressure for 3 to 5 minutes to decrease the blood flow. So it can precipitate the hypocalcemic tetany, carbopetal spasm. So what are the main causes of hypocalcemia? Common cause of hypocalcemia. Apply that same principle. One thing is
Decrease intake.
yeah, one thing is decreased intake. Other thing is
Increased excretion.
is excretion. Anything in between here for calcium? Calcium is a different thing which needs
Decreased absorption.
yeah. So it needs agents for absorption as well. Okay, so we'll go for the algorithm. So the mainly hypocalcemia is you need to, the next thing you need to check is the serum PTH level. So PTH level is very low in hypocalcemia. It is mainly hypoparathyroidism. Even sometimes in normal PTH, in hypocalcemia, you need to think of hypoparathyroidism, because in hypocalcemia, what do you expect in PTH level?
Increasing.
Yeah, so you need PTH has to go up. So it will cause bone resorption, which will increase the calcium. So even in hypocalcemia, your normal PTH is also suggestive of hypoparathyroidism. So no, don't leave that normal PTH also. Telling that PTH is normal, so it is not the cause. So what to expect in hypocalcemia is high PTH. So even if normal PTH, think about ruling out hypoparathyroidism. When you have normal PTH, you need to think of other things as well. Vitamin D deficiency. Even in vitamin D deficiency, you can have raised PTH. Normally, in any hypocalcemia, you need to have raised PTH if it is not because of hypoparathyroidism. So only one problem here is calcium sensitive abnormality where your PTH can be normal. That is the one thing exclusion. And other causes mainly vitamin D deficiency, renal failure, osteoporosis kind of things, hypomagnesemia. These are all main causes for your hypocalcemia. So always the workup starts with PTH. Another important thing is phosphorus as well. So these two things you need to add in your workup. So what is the management algorithm for hypocalcemia? You need to look for symptoms. Again, any child, you need to think of symptoms. Hypocalcemia, asymptomatic child, you just need to give oral calcium, no need for IV corrections. How much the calcium can be, you don't need to worry about giving IV correction. If child is having symptoms, and our child is having very severe hypocalcemia, child may thrown for the, you expect the child can develop symptoms soon, then you can go for IV correction. So you need to give IV correction. Then you need to continue IV infusion. Like you need to add it in the maintenance fluids, or you need to keep continuing some amount of IV calcium slowly over 24 hours. Then your symptoms have got better, and once child is able to take orally, the immediate thing you need to switch over to the oral calcium. Always it's better, any electrolyte abnormality, the management you try to better to give it orally if it's available and if child is able to take. And only in severe symptoms you need to give IV corrections. And second thing is once you stabilize you increase the calcium, you need to maintain the calcium. For that you need to correct the underlying cause. So look for the vitamin D deficiency, hypoparathyroidism, and hypomagnesemia. So the correction is usually 0.5 ml per kg of calcium gluconate. You need to dilute it 5 times. You can go up to 1 ml per kg also, but majority of the guidelines are telling in pediatrics, not in neonate. Neonate you can go to 1 to 2 ml per kg, but in pediatrics, try to restrict it to 0.5 ml per kg. If still symptoms are persistent, you can repeat. So better not to over give the calcium. That's what the main point here. So in pediatrics, the dose is 0.5 ml per kg. If child is symptomatic, again you can repeat it. That's what they are telling. But when you're giving calcium, the most important thing is you need to monitor the heart rate. You need to have ECG monitoring, or at least you need to put the finger on the pulse, or you need to auscultate the heart rate. So without this, don't try to give IV calcium. If you have any drop in heart rate by more than 10% from the baseline, that is if child's heart rate is 150 and it drop it to 135, so you need to stop the infusion and you have to wait for the heart rate to go up, and then you have to restart in a slower rate. So initially you started 15 minutes. Now you need to start over half an hour. So that is what, always remember when you're giving hypocalcemic correction, calcium corrections, you need to monitor heart rate. Always remember this one point, because many times we've seen the child is landing up in bradycardia when you're giving calcium corrections. So once you treated the symptomaticity and you given a calcium correction, then you need to give the infusion for 24 hours. So what is the dose for that is, in neonates usually it's 2 ml per kg per day, and 1 to 2 years it's 4 ml per kg per day, and child about 2 years, the maximum is 40 ml. So and you need to adjust it to response. So you need to repeat the hypocalcium levels, and you need to see child is symptomatic or child is asymptomatic now. So depending on that, you need to titrate your dose of infusion. It's infusion, it is not the bolus what you're talking about. The infusion is this. So symptomatic child, give the bolus, correct the symptom. When the symptom is corrected, start the infusion. At least give it for 24 hours. Meanwhile, if child is able to take orally, switch over to oral calcium. So our main aim to keep the calcium at least around 6.8 to 7, around 7, target for 7. And then your infusion from the calcium from GA can start. So meanwhile, you need to give vitamin D if the child is vitamin D deficiency, because observe whatever oral you give in severe hypocalcemia, severe vitamin D deficiency, it will not absorb. So that's why at least for 24 hours, try to give it IV. That is the reason for this IV infusion. In severe hypocalcemia, so you need to give IV correction, if IV infusion over, you switch over to oral. Once child started taking orally, and you can decrease the calcium infusion rate by 25%, and you can stop it. So the normal oral dose you'll reach is up to 100 mg per kg per day in 4 to 8 doses. So this is what the hypocalcemia management guidelines tells. And the guidelines can change from different units to different. And this is what the brief outline what I'm giving. This may not be applicable and this may not be followed in many units, but this is what the different units in the of India and outside of practicing. So I'm taken more whether the guidelines from Australia, UK, and New Zealand guidelines. In the recent IAP, the vitamin D dose what they given in nutritional rickets is less than 6 months. You go for daily doses, that is 2000 units. And 6 to 12 months, either you give daily dose or you can give them the cumulative dose once weekly or once monthly. And more than 12 months, you can go for the bolus doses. That is 60,000 units every 2 weekly for 5 doses. So that is for the recent 2022 IAP recommendations. So we'll move on to the last thing. And many times we keep giving bicarbonate corrections in metabolic acidosis. So how you will calculate that how much bicarb to be given? So how will you decide how much bicarb to be given for this particular child with this amount of metabolic acidosis?
So base deficit into weight divided by 4 in pediatrics, sir, by 6 in units.
So pediatrics by 4 and 6 in years. Okay. You got some 30 ml. You got 30 ml. So how much you take is a 10-year-old child, you got 30 ml of bicarb correction to be given. So how to give and in how much duration? So you got an ABG showing metabolic acidosis. You you calculated the formula. So like you told, weight into base deficit by 0.4, and you got around 30 ml. So how to give this 30 ml in how much duration? Others can also join because bicarb corrections will be commonly given. You can post it in the chat box as well. The formula is fine. We'll redefine the formula again. But the crux is that you got some amount of bicarb to be given. So how to give that amount of bicarb? How much duration? That's the main question. I mean, many of the PGs, when I they asked me this question. So how to decide on the duration of bicarb? So then I go back and check out the guidelines, because every unit has different protocol, different guidelines, different duration. So I just want to know what commonly the people are doing. Yeah, Kirtana, you can tell how much duration you're going to give. What do you commonly practice? That's what I'm asking. I'm not asking anything extra.
Over 1 hour we will give, sir, correction.
Yeah, over 1 hour. Fine. Any others? Any other unit people want to answer? Okay. The dose formula is correct. The base deficit weight into F. The F is 0.3 for infants and children, 0.4 for neonates, 0.6 for premature neonates. So 0.3 is the for children and infants. So only we'll correct the half of the base deficit initially. So whatever you calculate, the total amount you should not give. So what we are giving is the half, and the duration is different in different guidelines. So what I routinely followed in my PG time is you have over 8 hours, rest half or 24 hours. But I think many other units are still following that protocol only. But I had a practical difficulty with that, because you calculated for the base deficit at that moment. But in inborn of metabolism, the child keep producing the metabolic waste, and the bicarb keep decreasing. So you cannot treat like same value for 24 hours. So you need to keep repeating the ABGs, and you need to modify your formula again and again and again. So it's a practical difficulty. So strictly following for 8 hours and 16 hours, 16 hours, it's practically impossible, and I think it's not feasible for the many of the children. So that's what the given is. You can give it over 1 to 8 hours. That's what the given. So many guidelines tells that you can give it over 1 to 8 hours. So if you feel that child is not going to produce further metabolic acidosis, you can give it slowly. There's no harm. But if you feel that child is in like underlying IEM, like organic acidemia or like AK, where child can keep producing this acid, which can decrease the bicarbonate. So you need to try to get down the duration, depending on the severity of the metabolic acidosis. If child is pH is 6.8 or 6.9, you cannot give it over 8 hours. So you need to correct at least rapidly. So initial correction, at least you can give it over 1 or 2 hours. Then you repeat the ABG and decide on further correction little slower. So that is what I can suggest. In severe metabolic acidosis, give the correction little rapidly. But in neonates, the main problem is, so the bicarbonate contains sodium. So the rapid shift in the osmolarity can precipitate CNS issues like bleeding and all for them. So little careful. This guideline will not apply for neonate. So whatever I'm talking, the guidelines is mainly for children. So neonates is little different. So we'll see what neonates different guidelines what all about neonates. But in neonates, you need to be very careful when giving bicarb, because the bicarbonate contains sodium. The sodium, rapid rise in sodium can increase the serum osmolarity tissue, and it can cause bleeding in the neonate. So be careful in bicarb corrections in neonate. Very, very careful. So severe metabolic acidosis, correct rapidly, repeat blood gas frequently. Don't do only one blood gas in the morning and start the correction and repeat after 124 hours. So that's not feasible within sick children with underlying cause could be metabolic acidosis, IEMs and AK. So administration, if you are giving peripheral line, you need to dilute it 5 times. The minimum dilution for peripheral administration of bicarb is 5 times, because it is hyperosmolar and it can cause thrombophlebitis easily. In central line, you can give 1:2 dilution. That what not routinely will follow is 1:2 dilution. It's mainly for central line. In peripheral line, you need to administer 5 times dilution. But if you're dealing with AKA children, where your fluid status is already on the overload side and you cannot give that much amount of fluid in the through bicarbs, and you are having time for starting of RRT, you can give 1:2 dilutions. In central line, you can do directly. No need to dilute. In fluid restricted patients, but be careful with the line extravasation. If it got extravasated to peripheral line, it can cause much damage to the tissues there. So dilutants, you can use 5% dextrose, 10% dextrose, and sodium chloride. But the problem with the sodium chloride is, again, you're adding sodium extra. So already there is a sodium in bicarbonate, and you are adding NS, so your sodium content will rise rapidly. So always in neonates, try to give it through 5% dextrose rather than sodium chloride. So depending on the underlying sodium status and underlying age of the child, so you need to decide what dilution. It's better always dilute that with the 5% dextrose. It's easier for the, you don't remember about which child I want to dilute, which child I want to dilute with this. So remember that bicarbonate, you can just dilute with 5% glucose, 5% dextrose. That will be easier because it will not increase the sodium that much when you're adding with the NS. So in neonates and less than 2 years children, the rapid injection of hypertonic sodium bicarbonate is hyponatremia. So it can decrease series of pressure, and it can possible intracranial fluid. So be careful in this. And the rate of administration in such patients should be therefore limited to not more than 8 milligrammes per kg per day. So this is what the neonatal guidelines tell you. So the rate of administration in neonates and very young age infants. So you cannot go more than 8 milliequivalents per kg per day. So these are the guidelines given by UK, Australia, mainly they're following this thing. And in emergencies such as cardiac arrest, you infuse very rapidly, because if you don't give very rapidly, the child can die, even in neonate. So only in cardiac arrest situations, you need to give rapid bicarbonate injections in less than 2 years and neonates. But other situations, when you're dealing only with IEM like metabolic acidosis, give the bicarbonate injection very slowly in neonates. Be careful in bicarbonate administration neonates. You cannot give it faster, except in situations like hyperkalemia leading to ECG changes, causing cardiac, almost near cardiac arrest, or in cardiac arrest. try to give very slow bicarbonate injections in neonates. Okay, so with the last slide, so when you encounter multiple electrolyte abnormalities, what you're going to do, how you're going to approach these children, say hypokalemia, hyponatremia, and hypocalcemia. This particular child had 3 electrolyte abnormalities. So what you're going to do first, you're going to correct all the 3 at the go, or you want to treat it something, and next you want to do little extra things for others. Okay, we'll go to one by one scenario. So this particular child had hyperkalemia and hypernatremia. So what are you going to do? Hyperkalemia and hypernatremia, what are you going to do? You're going to correct both of them simultaneously, or you want to do correct once hypernatremia first or hyperkalemia first, then address the second thing? So whenever you encounter multiple electrolyte abnormalities, so you need to decide which is the most priority one for me. So whether I am, if I won't treat hyperkalemia, the child can worsen. If I don't treat hypernatremia, child can worsen. You have to decide. So what the main important thing is, which one is more critical here and which one is causing more symptoms here. So if the child had severe hyperkalemia and child is showing ECG changes, I am not going to bother about hypernatremia immediately. So I am going to correct the hyperkalemia first. Then meanwhile, I will start the management plan for hypernatremia. And because hypernatremia children, if the child is very lethargic, CNS symptoms are there, and hyperkalemia is like potassium is only 6.1, there's no ECG changes. And I will not little worry about hyperkalemia per se there. I will start treating about hypernatremia, and along with that, hyperkalemia, stopping the fluids containing potassium. If I want to give, I can give salbutamol. Once I stabilize the child for hypernatremia, then I will start doing all these things. So it's based on any multiple abnormalities. Just look for which value is very critical, and if you don't treat that immediately, the child can collapse. So that is what the first priority here. And the second point is, if you start treating one electrolyte abnormality, whether it can alter the other abnormality. So for example, in hypokalemia and hypomagnesemia will cause hypokalemia. So hypomagnesemia per se will cause hypokalemia. So once you correct hypomagnesemia, some amount of potassium can increase by itself. But if the child is having severe hypokalemia and having muscle weakness, you cannot wait for just giving hypomagnesemia. So you need to give potassium correction. Along with that, you need to suspect hypomagnesemia. You have to give magnesium correction as well. Because magnesium, without correcting magnesium, your potassium cannot be corrected. Mild symptomatic hypokalemia, along with hypomagnesemia, correct the hypomagnesemia first and see for the response in potassium. And still potassium is low, you can correct it slowly. Symptomatic hypokalemia with muscle weakness, start giving potassium correction. Along with that, try to give the magnesium as well simultaneously. Because how much ever potassium you are going to give, without correcting magnesium, you cannot improve much. The second situation. And hypocalcemia and hypokalemia. So what are you going to do in this situation? Hypocalcemia and hypokalemia, how they both are related? Is there any relation? There's not much. Depending on the symptoms and severity, you need to decide. So this is the one important thing. Hypokalemia and hyponatremia, they both have relation. Your potassium correction can shift the sodium outside the cell. So increasing potassium can shift the sodium outside the cell because, any explanation? How potassium correction, increasing serum potassium can shift the sodium outside the cell. What is the relation between potassium and sodium status in the cell? Where potassium is high, inside the cell, outside the cell? Where the sodium is high, inside the cell, outside the cell?
Potassium inside the cell is high. Sodium outside the cell is high.
Okay, so in hypokalemia, what the cells try to do? So you have lower potassium in the serum. So what cell will do?
Push out the potassium from cell to
Some of the
outside.
potassium will be shifted out. So to maintain that ionic whatever equilibrium, sodium will move in. Understood? So when you start correcting hypokalemia, so once you start increasing serum potassium, then the shift will reverse. So automatically the sodium will go. So then once you corrected potassium and sodium gone up, then you start correcting the sodium from there. Before thinking the thing and you start giving treatment for hyponatremia also, then you will do more correction for hyponatremia, rapid correction. So that's why always remember, when you have two electrolyte abnormalities, always try to link them up. So whether I'm treating one, it can alter the other, and which is more symptomatic at that moment. If this particular child had severe hyponatremia, child is having seizures, you don't need to wait for the hypocalcemia correction. You need to start giving 3% NS along with calcium or potassium correction, and the rest of the correction depends on the next value. But child is asymptomatic hyponatremia and child is having symptomatic hypokalemia, and you're giving correction for hypokalemia, just wait for the sodium correction. You give potassium correction, see for the improvement in sodium. From there, you start correcting sodium. I think I'm clear what I'm talking. So if you have multiple electrolyte abnormalities, try to see which is more symptomatic, which is more critical, and treat that at first. And by treating that, can I alter the other electrolyte abnormality as well? I can increase that one or decrease that one. Based on that, you need to cut the next value, other electrolyte abnormality. So with this, we ended the topic, and for take-home messages. So children with any acute illness or condition affecting the input, distribution, output of electrolytes and the fluid in the body are at risk of electrolyte abnormalities. Any child admitted to the hospital has the risk for electrolyte abnormalities. That's all. And errors in sample collection or processing may lead to inaccurate electrolyte values. So it's essential to consider the clinical context. You are having potassium of 7 report, but child is very asymptomatic. There is no ECG changes at all, and there is no clinical context. The child is not having AKA, child is not having potassium supplements. It is very tricky value. So we need to repeat the value. But if the child is symptomatic, like child is having ECG changes and child can develop, child is already having potassium supplementation, then you need to take that value and you need to treat that value. Now always look for the age appropriate normal ranges from your local pathology service. So different labs has different methods of electrolyte measurement, and they have different cutoffs. Always follow the local your lab values. And all critically abnormal test results should be acted emergently. You cannot delay that. You cannot think that this is spurious value when child is already having symptoms. And electrolyte abnormality should be corrected mainly by oral or enteral route whenever possible. So this is one thing I want to stress here. Majority of the people just need oral corrections. No need for IV corrections. Very less people we need IV. But if the child is in critical state, don't deny the IV correction. You need to give the IV correction. Then once child is stabilized, switch out to oral corrections. It could be hypocalcemia, it could be hypokalemia, so anything. So once you given the IV correction, child is improved and the critical value is gone and it's only mild hypokalemia, hypocalcemia, you timely switch out to oral. So with this, we'll end this final session on dyselectrolytemia. If you have any doubts, we can take, otherwise we'll end the session. So electrolytes is very vast thing. We'll feel that electrolytes will do routinely. We know everything about how to manage electrolytes, but still after this many years, I still have doubts in electrolyte management. I'll always go back and refer the standard textbooks, standard guidelines, how to manage electrolyte imbalances. So management part is easy, but identifying the cause is very difficult in electrolyte abnormalities. So always try to do the basics correctly in electrolytes. So I'm going to share this PPT in the group. So always, if you have any doubts in management means that how to give calcium correction, how to give potassium corrections, you can go through it. It is a standard guideline. It's not I designed guidelines. It is the standard guidelines from taken from the UK, US, and Australian guidelines. If no doubts, we'll end the session. And next session will be on ABC and CBC by Dr. Ranjit. And he's a very good speaker. He's an hemato-oncologist. And please don't miss that session. He'll give the different case scenarios where you get the different CBC values and how to interpret that values.
Sir, one doubt. How many times you can correct the half bicarbonate in 24 hours?
It depends on your ABG status. How symptomatic is the child and how severe is the ABG pH. If you are correcting, but still the pH is 6.9 or 7, it's not moving beyond 7.2. The normal target, what you do for the ABG correction is at least we'll try to keep it around 7.15 to 7.2. In shock patients, at least we'll try to keep it about 7.2. So at least for stable patients, at least we target 7.1, at least 7.1 above. But still after half correction, your ABG showing pH of 7.0 or 6.9, I think you need to correct it. You cannot delay that thing.
Thank you, sir.
And there is no clear-cut guidelines how much you need to give, how much. But in neonates, try to restrict it. But in pediatric age group, there is no clear-cut guidelines. What we routinely follow is we keep repeating the bicarb correction until you start something. Like if you start petrol dialysis, you can stop the potassium, the bicarb correction. Or you started some amount of renal replacement therapy in AKI, you can stop it. In IEMs, you kept NBM, you started supplements like carnitine, thiamine, everything, and by next 12 to 24 hours, the bicarbonate improved, then you can stop it. It depends on the severity of the ABG, how much pH you are targeting. So basically, we'll target around 7.15 to 2 in stable children, more than 7.2 in shock children, hemodynamic unstable children. That's what we usually will follow. So till we achieve that thing, we keep repeating. And it depends on the duration, depends on the severity. If you have 6.9 pH, 6.8 pH, I give very rapidly, like 1 hour. If your pH crosses 7, 7.05, 7.1, then we give slowly over 2 to 3 hours.
Thank you, sir. Got now.
If no doubts, we'll end the session. Thank you for your patient hearing.